Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Everyone, thanks for joining today. I'll do my best to sum up some things from the conference that seemed interesting. Full disclosure, I did not attend the conference. And Dr. Tapley a few weeks ago reviewed things that made the biggest headlines. And then I was just sort of digging through other things that came up at the conference because I was interested and we didn't have a speaker today, hence part 2. So an acknowledgement to our funders. I have no financial disclosures or conflicts of interest. Again, I didn't attend the conference. If you did, and if I get anything wrong, please jump in and educate me. Let's start with an abstract about PrEP, specifically about viral load monitoring and results for individuals receiving long-acting cabotegravir PrEP. So we have talked about HPTN 083 and long-acting injectable cabotegravir for PrEP. I think majority of this audience is familiar with that trial and the results. And we've talked about how retrospective data showed that using RNA or viral load tests in that trial identified HIV earlier and often identified new HIV infections before integrase resistance had developed, meaning that if viral loads were used, the suggestion is it could have caught new infections earlier and potentially could have prevented development of integrase resistance. The message there was that viral load monitoring could be important, and that is included in the current CDC PrEP guidelines. This study I thought was interesting in the open label extension. So this is the part of the trial after the DSMB sort of stopped enrollment and randomization and everyone was offered injectable cabotegravir. What happened for those who chose to receive the long-acting injectable as PrEP, there were regular HIV screening done, including a rapid test, an antigen antibody lab test, and an HIV RNA. This analysis specifically looks at those RNA screening results, of which there were over 26,000, and specifically looked at the instances in which only the RNA was positive. So in those cases in which all those screening tests were done, the RNA came back positive, but the rapid test and antigen antibody were negative. The investigators wanted to know, what did that mean? So overall, of those 26,000 plus RNA screens, there were only 27 in which there was an isolated RNA positive, meaning only the RNA was positive. Of those 27, 22 were adjudicated by a panel of experts as false positive, 5 as true positive. The investigators noted that of those 22 false positive results, 7 led to delays in cabotegravir dosing, and you can see I just put here the median range of what the RNA level was in those isolated RNA cases. And you can see in those that were false positive, the median was below the limit of quantification, and overall the values were pretty low. Those that were later adjudicated as true positive results that actually indicate HIV infection tended to be higher. But then when the investigators went back and calculated the overall positive predictive value of having a single positive RNA lab result for individuals receiving injectable cabotegravir PrEP, the positive predictive value was quite low. Overall, 18.5% if individuals, or in the subset of individuals who had received a dose of CAB-LA within the prior 6 months, even lower at about 9%. If an individual had delayed or missed an injection and not received it within the prior 6 months, it was higher, but still only 60%. So the conclusion is, in this preliminary analysis, a single positive RNA result performed as part of screening for HIV in individuals receiving CAB-LA PrEP really did not perform well. It was a rare event and the positive predictive value was low. It was usually a false positive. So if you see this happen, the appropriate next step is simply to repeat it. This actually came up for me in clinic, not in someone receiving CAB-LA, but in receiving oral PrEP and was getting regular screening with antigen antibody, rapid test, and RNA, which is a consideration in the guidelines. And a qualitative RNA came back positive. It was the only thing positive, and it led to a lot of anxiety. It led to missed doses of PrEP. It led to a lot of repeat testing. In the end, it turned out to be one false positive qualitative RNA result. So I think punchline of this study is if you are screening with RNA for PrEP and the RNA comes back as the only positive result, repeat it, don't necessarily delay PrEP, and most often it's going to be a false positive result. Rafi Landovitz, who presented this, did comment that updated PrEP guidelines should take this data into consideration. So we'll have to see what new guidelines say about RNA monitoring, both with CAB-LA and with oral PrEP. Stay tuned for more. That's the only PrEP abstract I'm going to include today. The rest will be treatment. If you have questions or thoughts about that one, we'd love to hear it at the end. Let's turn to a study of switching to dolutegravir 3TC in the setting of prior virologic failure and prior documented 184V or I mutation. This study was named SOLAR 3D. It was a prospective open-label comparative study. I did a fair amount of digging, and at no point in any description of this study could I find a description that it was randomized. So I really couldn't confirm how they decided who would go into which arm of this trial, and I would say that's my big criticism of this study. That said, the results are in line with others, and I thought it was worth mentioning. Individuals were included in the study if they were over age 18, had a suppressed viral load for at least 6 months, on a stable 2, 3, or 4 drug regimen. All individuals in this trial had prior virologic failure and at least 2 prior ART regimens, and they did not exclude anyone based on CD4 count, integrase experience, past NRTI resistance, presence of M184V or Q65R on a baseline genotype. And individuals all got dolutegravir 3TC, and then they compared the group who had a history of M184V or I versus those who did not have that history. You can see some of the baseline data at the bottom there. So really, this is a comparison of switching to dolutegravir 3TC or dolutegravir lamivudine with or without an M184V or I mutation. Punchline on the results is that whether or not individuals had an M184V, they tended to do very well. Viral loads tended to stay suppressed. There was no difference in the rate of virologic suppression, confirmed virologic failure, or viral blips in those who had or did not have an M184V or I mutation. The suggestion here is that dolutegravir 3TC is sufficient even if there is an M184V or M184I present. Now, I would buy that. We don't use dolutegravir monotherapy, but there's quite a bit of data now that dolutegravir plus, even a little bit of extra, plus some not fully active meds tends to be sufficient, especially for individuals who have had longstanding viral suppression. And again, this study is in line with some others, including a systematic review that suggested that dolutegravir lamivudine does tend to be effective even with an M184V. I can't say I've reached for it in the setting of an M184V a lot in clinical practice, but if that were the best option, a person had long-standing viral suppression and I felt like they were going to adhere to it well, I would consider it. I just wanted to show one other interesting piece of this study. On the right in this table, you can see the group that had an M184V on a historical traditional RNA genotype and the group who didn't, 50 in each arm. This row, proviral genotype, is those who got a proviral or DNA or PBMC genotype at baseline, so not everyone did. But just look at this column with M184V on a historical RNA genotype. Of the 41 who also got a proviral genotype, only 15 of the proviral genotypes actually found that M184V that was previously there on an RNA genotype. 37% of those with a known past RNA genotype M184V, it was then identified on a proviral genotype. So we talk about the limitations and the imperfect sensitivity of the DNA proviral PBMC genotypes, whatever you want to call them. And I just thought that this was a good example of what we mean. If the proviral genotype does not find it, does not mean it's not there. If it finds it, it tends to be pretty good. But if it does not find it, does not mean it's not there. Let's turn to another study of switching ART. This is a study that compares a switch to dolutegravir 3TC versus a switch to BIC/TAF FTC. I kind of like this study because those tend to be my 2 most frequent go-tos for switching ART in clinic. This study was called Paso Doble. The studies of dolutegravir 3TC tend to have creative names like salsa and tango, and Now this one, so this was a phase 4 randomized, in this case randomized, open label trial conducted in Spain. This was adults with suppressed viral load for at least 6 months while taking ART, as you can see described here. In this case, no prior virologic failure, no known or suspected resistance, no prior use of dolutegravir or bictegravir, and importantly, no hepatitis B, because you would not want to randomize individuals with Hep B to get dolutegravir 3TC. Their endpoints were virologic efficacy and also weight change. I put a little bit of data about the baseline ART there that you can see. So really it's a comparison of people with well-suppressed HIV, long-standing viral load suppression, switching to Big TAF FTC or dolutegravir 3TC. Again, really no difference in efficacy in terms of virologic suppression, virologic failures, viral blips, also no major differences in tolerability. Again, I find in clinic, in the absence of sort of complex salvage regimens, complex ART resistance, these tend to be my two sort of go-tos for helping people update, switch, and simplify ART. I found the results about weight change a bit confusing. Curious to hear your thoughts. This is the difference. This is my recreation of their graph over 48 weeks. You can see the overall average weight change was higher in the Big TAF FTC compared to the dolutegravir 3TC group by about 1 kilo, about 2.2 pounds. Was statistically significant. I don't know how clinically significant that is. But then what I found confusing in the Big TAF FTC group, the weight change after the switch really seemed to depend heavily on the pre-switch regimen, with most weight gain occurring for those who before switch were taking TDF or efavirenz, and we've talked about how those meds tend to suppress weight to some way we don't understand. So that kind of makes sense to me. It was very dependent in that group on the pre-switch regimen. But then in the switch to dolutegravir 3TC, it really did not appear to be dependent on the pre-switch regimen. Regardless of the pre-switch regimen, everyone kind of tended to gain a similar amount. So I can't really explain that. I don't know why the pre-switch regimen would affect the switch to Big TAF FTC and not the dolutegravir 3TC. Maybe it was just not powered to detect differences in the dolutegravir 3TC group. I don't know. I can't fully explain it. I'm not sure how clinically significant that is, but it did get some attention at the conference. Let's turn to things that are not approved yet, but maybe coming in the future. So this is another ART switch study, but here for individuals taking complex ART regimens who really need to simplify to new classes of medications. So this trial called Artistry 1 was a switch to daily oral bictegravir with daily oral lenacapavir at 2 different doses as compared to continuing the baseline regimen. So this was a phase 2/3 open label randomized trial. Adults with suppressed viral loads for at least 6 months who were taking a complex ART regimen enrolled. You can see their definition of complex ART used for the trial there at the bottom. Enrollees had no prior lenacapavir exposure and no bictegravir resistance, no hepatitis B, again, and all had estimated GFR above 15. I've given you a few basics about the participants. You can see here, in general, they were individuals who were taking what we would consider to be relatively complex regimens, and there was no integrase resistance, but there were fair rates of NNRTI, NRTI, and PI resistance. The comparison looks at virologic efficacy at 48 weeks. You can see here the different arms, a bictegravir solo tablet, which is not currently approved, an oral daily lenacapavir tablet at 2 different doses, and a comparison to the baseline regimen. Randomization was 2 to 2 to 1, and you can see here the numbers in each arm. Overall, the virologic efficacy was quite high and quite good in all of the arms, and there was no statistical difference in the virologic suppression rate at 48 weeks or in the virologic failures. What is going to go forward for future study is bictegravir plus lenacapavir 50 milligrams. I don't totally know how they chose that len dose, but I know that's what's going forward, with potential that this could end up in a combination tablet and could be a new option for simplifying ART in the future. I think this combination of integrase plus capsid inhibitor is something we're going to see more and more of. There are new long-acting integrase inhibitors in development. And then as we've talked about before, I think we're going to see more and more about the NRTTI, islatravir, and lenacapavir as well. That combination has potential for weekly oral dosing. So for folks taking complex regimens who may need Simpler regimens, drugs in new classes, folks who have past resistance but no resistance to integrase. I think we can counsel people that there are new options coming. A couple more abstracts before I wrap up. I thought this was an interesting new look at the question of whether abacavir increases the risk of major adverse cardiovascular events. Investigators from the Reprieve trial, which we've talked about, went back and asked this question. I won't go through everything again about what Reprieve is. Here's a reminder about the inclusion criteria. And you probably recall that the comparison was pitavastatin to placebo. This analysis simply looked at the risk of major adverse cardiovascular event with current abacavir exposure, prior abacavir exposure, or no abacavir exposure. And the punchline is that current or former abacavir exposure did seem to increase the risk of major adverse cardiovascular event. You can see here the adjusted hazard ratios and 95% confidence intervals for former abacavir use and current use. There was no association with these other medications. And you can see on the right, my recreation of the graph of the cumulative incidence of major adverse cardiovascular event for those individuals who fit the categories of current abacavir use, former abacavir use, or never abacavir use. So more data now from a very large, well-conducted randomized control trial that yes, abacavir does increase the risk of major adverse cardiovascular events. I am really getting away from abacavir. I will just share and coming back to switches to dolutegravir 3-TC. A lot of my folks who are taking dolutegravir, abacavir 3-TC, I have simply switched to dolutegravir 3-TC to avoid the abacavir issue. I can't remember the last time I started someone on dolutegravir, abacavir 3-TC. I don't even check B5701s at baseline anymore. I just really have gotten away from abacavir for this and other issues. I'd be curious to hear about your practice too. Finally, I'll end with this. The 7th reported HIV sustained remission case, some would say cure case. This individual has been dubbed the next Berlin patient. You probably remember the Berlin patient, Timothy Ray Brown, who was the first documented case of sustained HIV remission after stem cell transplant. And Timothy Ray Brown unfortunately passed away a few years ago when his leukemia recurred. This individual, called the next Berlin patient because the stem cell transplant was also done in Berlin, was a white male born in 1964. So 60 years old, HIV diagnosis in 2009. He had a sample from 2014 that showed that he was heterozygous for the CCR5 wild type and the CCR5 delta 32 mutation. Just remember that HIV enters the T cell via CCR5, and individuals who are homozygous for that delta 32 mutation seem to be resistant to acquiring HIV. This individual himself was heterozygous, so that's not the most important part of the case history. He didn't start ART until April 2015, and then he developed AML that same year. And then he underwent a stem cell transplant in October 2015 from a donor who was also heterozygous for CCR5 wild type and delta 32. So not homozygous, but heterozygous. I think that's the most unique part of this. The donor was heterozygous for wild type and for the mutation that eliminates the CCR5 co-receptor from the T cells. ART was interrupted in 2018, and this individual seems to have sustained remission for at least 5.5 years. There have been a lot of tests to try to find evidence of active replicating HIV, and none of them have. So what I've added here is just a summary of the 7 cure cases to date. 4 had donors who were homozygous for the CCR5 delta 32 mutation, 1 heterozygous, this patient. There was 1 individual, also the 1 woman in the list of sustained remission cases, who received homozygous and wild type. That was from umbilical cord cells. There was 1 individual thought to be in sustained remission who received wild type stem cells. 4 of the 7 received intensive conditioning chemo, and 2 developed severe graft versus host disease. The question is, what part of this or what combination of this is necessary for an HIV quote-unquote cure for sustained remission? And that is not what's known. Obviously, we are not offering stem cell transplant to all of our patients. It's expensive, it's dangerous, it's not readily accessible, but we do hope that something useful is learned that can be translated to other more accessible therapies. Again, what is not known what is necessary in terms of the donor stem cells, what is necessary in terms of the conditioning chemo. Is there some role for the graft versus host for suppressing the HIV as well? So I'll stop there for time. Happy to take any questions.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.